Hello everyone, hope you're all doing good. This is Dr.G and we are going to discuss about male infertility in this video. Already we have seen what are the definitions of infertility and all. Okay, now let's go on to speak about male infertility. Okay, so male infertility, first let me tell you what are the etiology of infertility and how much important male infertility is it. Okay, so etiology of infertility can be due to male factors, which is around 30%, then female factors can contribute to about 40 to 55%, and then both male and female factors will be seen in 10 to 20% of the infertility cases, and some cases will be unexplained. Okay, so that will constitute about 10 to 15% of the cases. Okay, so these percentages are also important for you, right? Okay, now coming on to the next one, how important male infertility as such it is. Okay, so what is male infertility? Male infertility means, so it is the inability of a male to result in pregnancy in a fertile female. Okay, so the most of the abnormalities in male infertility are seen with semen. Okay, so there is semen abnormalities where we will be seeing alteration in the sperm concentration, motility or morphology. Okay, so that's it, right? Now coming to the physiology in the male. Okay, the reproductive physiology in the male. Okay, so this is also important to understand about the other parameters as well. Okay, so hypothalamus is the higher center which will be acting on the pituitary, and this will be acting on the testes in case of a male. So what are the hormones coming from hypothalamus? Yes, it is the gonadotropins. That means gonadotropin releasing hormone. Okay, so this gonadotropin releasing hormone will be coming and acting on the pituitary to produce gonadotropins. What are the gonadotropins? It is follicle stimulating hormone and the luteinizing hormone, and finally we have the testes. In testes we have two different types of cells, right? So what are the two different types of cells? It is the Leydig cells and Sertoli cells, right? Now what happens is, luteinizing hormone is going to act upon the Leydig cells, and this is going to produce the hormone testosterone. Okay, so this is going to produce the hormone testosterone, right? And then what is happening with the Sertoli cells? Okay, Sertoli cells means these are supportive cells, we all know, and FSH is going to act on the Sertoli cells. Okay, so this thing you have to know. Okay, so finally the hormone testosterone is produced by the Leydig cells. Now this testosterone hormone is going to have a negative effect on the pituitary as well as the hypothalamus. It is negative effect. So when a certain amount of testosterone is produced, okay, it will be giving a negative feedback to the hypothalamus and pituitary, saying that sufficient amount of testosterone is available here. Okay, so that one you have to know. And then let's speak about spermatogenesis as well here. So sperm development is the spermatogenesis. Okay, where it is going to take place? It is going to take place in the Yes, seminiferous tubules of the testes. Seminiferous tubules of the testes. Okay. So, how many days it is going to take place? It is going to take place for 70 to 74 days, and adult male is going to produce about 100 to 200 million sperms per day. Okay. It is per day, 100 to 200 million sperms per day are produced. Okay. And finally, it is not only about the production of sperms. Okay. So, production of sperms is like, it is like a kid. Okay. Then finally, it has to get matured. Okay. So, there is a specific place for maturation as well. Okay. So, maturation of sperms is going to take place in the epididymis, and then transportation of sperms will be taking place via the vas deferens. Clear? So, this is how spermatogenesis is going to take place. And I just want to give a short representation of how the sperm is going to look. Okay. So, this is how it is going to look. Okay. So, this is a short representation of the sperm. It is a rough representation as well. Okay. Now, if we see the structures, we have the tail or the flagellum. Okay. Surrounding this, you will even have a plasma membrane. Okay, like this. So, this is a plasma membrane. You will have the middle piece. Okay, so this is the middle piece, and remember, this middle piece is nothing but the mitochondria. Okay, and this is the neck. You will also have something called as centrioles over here. Okay, so there is centrioles, there is nucleus as well. Okay, and here if you take, this is the acrosome. Okay, so this is the acrosome, and finally this is the head. Okay, so if we clearly see the picture, sperm consists of three parts. Okay, one is tail, another one is middle piece, another one is head. Okay, so tail is the flagellum, middle piece you have the mitochondria, and in the head you have something called as acrosome and the nucleus as well as the centrioles. Okay, that's what you have to know. Now, let's see about semen. Okay, what are the components of semen? If we take semen, you have two types of components. Okay, either it can be cellular components, okay, and some secretions as well. Okay, so what are the cellular components you have? So, mature sperm itself is a cell, right? So, you have mature sperm, then you may have epithelial cells of the urogenital tract, then you have round cells, that is leukocytes, and immature cells as well. Okay, and if we take the secretions, we have secretions that is coming from the testis, epididymis, then you have glycerophosphocholine, then neutral alpha glucosidase, you have free L carnitine, and then you have fructose as well. Okay, so this fructose as well as prostaglandins are being released from the prostate. Okay, as well as you will be having other minor components of zinc, then prostate specific antigen and mucin as well. Okay, so these are all present. Okay, these are the secretions, right. The next one is, you have to know the physiology of the semen after ejaculation. Okay. Now, first point is, it is going for liquefaction. So, liquefaction, if you take, it is semen as such is a thick gel at the time of ejaculation. Okay, so it is a thick gel and it normally takes 20 minutes to become a liquid one. Okay, so this 20 minutes period is known as the time taken for liquefaction. Fine. And the next one is capacitation. So, capacitation is an activation process. Okay, it is a activation process. It involves enhancement of the flagellar activity. Okay, enhancements of the flagellar activity, and it also brings some biochemical and structural changes, okay, in the plasma membrane of the sperm head. The plasma membrane of the sperm head. Okay, so these are the two processes that are involved in capacitation, and remember, capacitation is an activation process. Okay, fine. Now, we also have some other thing that's happening, that is acrosome reaction. So, what is acrosome reaction? Here, the vesicles that are positioned in the sperm. Okay, so the vesicles positioned in the sperm close to the plasma membrane. Okay, so it combines together, all the vesicles are going to merge together and is going to produce proteolytic enzymes. Okay, so with acrosomal reaction, what is going to happen is, all these all these vesicles are going to merge together and there is exocytosis, so that the enzymes that is present within these vesicles are released. Can you understand? Yes. Now, let's now see what are the different causes of male infertility. Okay, so what are the causes of male infertility? Male infertility can happen at any compartment. Okay, so from physiology we have to see, it can occur at the level of hypothalamus itself. So hypothalamic pituitary disorders at the level of CNS. Okay, so hypothalamic pituitary disorders can cause male infertility. Then the gonadal disorders, okay, that is the testicular disorders or the primary gonadal disorders can be responsible as well. And finally, it's not about the gonads. Then after the semen is produced, it has to be transported. Okay, that point also we saw, right? So there can be disorders of the sperm transport also. And finally, it can be idiopathic also. In most cases, it can go also as idiopathic. That means no specific cause can be found. Okay. So, if you see, approximately hypothalamic pituitary disorders are going to constitute only 1 to 2% of male infertility, whereas primary gonadal disorders are constituting 30 to 40% of male infertility. Disorders of semen transport will be around 10 to 20%, whereas idiopathic as such constitutes about 40 to 50% of male infertility. Right? Okay. Now, we'll go on to the next one. So, let's discuss about etiology of male infertility. Etiology of male infertility can be again seen at 3 levels: pre-testicular, testicular and post-testicular. Okay. So, obviously, when we say it is pre-testicular causes of male infertility, so which compartment we are discussing? Yes, it is going to be the CNS once again. So, it is hypothalamic pituitary disorders. Then there can be other conditions like thyroid disorders can also affect here, and then there can be adrenal disorders or liver failure. Okay. So, if you imagine the human anatomy, all these things are coming before the testis itself. Okay. So, hypothalamic pituitary disorders, thyroid disorders, adrenal disorders as well as the liver failure. And the next compartment we are going to discuss is the testicular causes as such. So, testicular causes means we can have chromosomal abnormalities, cryptorchidism, local conditions like trauma, varicocele, orchitis. Orchitis means inflammation that is happening, and it can occur either due to tuberculosis or mumps. Then even exposure to heat and toxins at the workplace, radiation, chemotherapy, substance abuse and smoking. Okay. So, all these can affect the testis directly. So, I will tell these conditions once again. It can be chromosomal abnormalities, cryptorchidism, local conditions like trauma, varicocele or orchitis which can happen due to tuberculosis or the mumps. Then exposure to heat and toxins, radiation, chemotherapy, substance abuse and smoking. Okay. Now, let us see about the post-testicular causes. So, post-testicular causes means these causes are important because post-testicular anatomy is important for the transportation of the sperms, right. So, what are the causes? There can be a block in vas deferens or epididymis. There can be congenital vas aplasia, erectile dysfunction, then anti-sperm antibodies can also cause this condition. Okay. Now, with this one, so we have understood totally what is male infertility, what are the physiology of male reproductive system and where and all we can have block, how the different types of male infertility are classified. Now, we are going to discuss about the history taking in a male. How you will go for history taking in a male infertility. Okay. So, history taking means 1. First point is pregnancy rate decreases after 50 years of age. Okay. So, not only the age of the female is important, but the age of the male is also important. But males are found to make pregnancy even in their 90s or 70s like that. But what is being said is that the rate of pregnancy is going to decrease after 50 years. Okay. Second one, you have to ask about the occupation. Okay. So, whether they are working with pesticides, there is a history of prolonged bicycling, hyperthermia is there, or any stress is there. Okay. And then a history of childhood diseases should also be obtained, which should include if there was a history of undescended testes or there was any history of mumps or tuberculosis, which would have been the cause of orchitis leading to male infertility. Okay. And the next one is you have to ask about the past medical history. Past medical history should include various disorders. Okay, so we have seen now, it should include mumps, tuberculosis, leprosy, syphilis. Okay, if there was renal failure, diabetes, hypertension, liver disease, or multiple sclerosis also. Okay, so all this history should be got. And the next one, you have to even ask specifically about some past medical history, that is chronic respiratory disease. Okay, I'll tell you how this is important. Chronic respiratory disease. First condition we can have is Young syndrome. Okay, so if they are a case of Young syndrome, then there can be epididymal obstructions. Second one is cystic fibrosis, where there is congenital absence of vas deferens will be there. And the third condition is Kortnager syndrome. In Kortnager syndrome, you will have immotile sperms. Clear? So, this is how chronic respiratory disease is important. So, other than this, you have to ask history about endocrine disorders also. Endocrine disorders include your hypothyroidism and hyperprolactinemia. Okay, so this history is also important in the male infertility as well. Okay, and then we have to obtain the surgical and trauma history, whether there was a history of trauma, torsion, vasectomy, or orchidopexy. Not only this, we will be asking about the personal history as well. So, personal history will include if there was a history of smoking, alcohol, then radiation, heavy metals exposure, and estrogen exposure. Okay. Then you have to ask about the drug intake history as well. Okay. Certain drugs specifically to be asked are if they are on antipsychotic medications or any anticonvulsants or sex steroids like that. Clear? Next one is you have to ask about their sexual history also, if there is a history of sexual dysfunction in them. Okay, which will include erectile dysfunction, premature ejaculation, or retrograde ejaculation also. Clear? Right. Now, let us see how we are going to examine this male. Okay, so examination. General examination we have to do, which will include your height and weight, then your secondary sexual characters, as well as you have to look for gynecomastia as well. Okay. Then if you go for local examination, you have to look the scrotum. Scrotum can show signs of hernia, hydrocele, or varicocele. Then testis, whether it is present or absent. If it is absent, means it is undescended testis. Okay. When the testis is present, you have to know the normal parameters. Okay. So normally the volume would be around 18 to 20 milliliter. That would be measured by a Prader orchidometer. Okay. And less volume. Okay. Suppose if this is less volume, then you have to suspect Klinefelter's syndrome. Clear? Right. Now, the next examination would go for penis. In penis, you have to check whether there is hypospadias or phimosis. Right? The next one is epididymis and vas. While examining this, when there is a congenital bilateral absence of vas difference, it is seen in cystic fibrosis. You have to suspect cystic fibrosis in that case. Then epididymis, when you examine, if there is enlargement of the epididymis and it is tense, you have to suspect obstruction is present some way. And finally, if tenderness is present, then you have to suspect inflammation due to any reasons. Okay. So, local examination doesn't end with this. You have to also go for prostate examination. Prostate examination can be done through a rectal route. Okay. And if prostates, okay, in prostate, it becomes, if there is prostatitis, it will become tender, enlarged and irregular. Okay. You have to understand this point. Fine? Yes. Next one, let us discuss about how we are going to evaluate a male infertility. Okay. What are the possible routes? Then we will discuss one by one. Okay. So, male infertility evaluation. Okay. So, our aim during male infertility evaluation is number 1, to find the specific cause and correct it. Number 2, individuals who can be offered other options like IUI or ART. Number 3, the next level of suggestion you can offer if there is a failure in IUI or ART is adoption. Adoption, or sometimes you can even offer donor sperm option, okay, who are not candidates for ART. And finally, one important aspect is that you have to treat the underlying medical condition, what it is present, whatever it is present, right? So, you have to treat the underlying medical condition as well. Clear? Okay. Now, tell me, what is the first investigation you will offer? First and the foremost investigation you think when you want to evaluate male infertility? Yes, it is semen evaluation. Very important, right? Yes. Okay. Now, let's discuss something on semen analysis. Semen analysis is the first investigation to be done. Okay. So, it is the first investigation to be done. You have to obtain sample of semen after an abstinence period, and remember the abstinence period shouldn't be too short or too long. Okay. So, obtained after an abstinence period. Say we can roughly keep it around 2 to 3 days, and maximum 7 days of abstinence can be allowed. Clear? And if it is shorter period, what happens? If you obtain it very shortly means what happens? There is decreased volume and density. Suppose if you obtain it after a longer period of abstinence, then there is increased volume and density. But remember, the proportion of dead, immobile and the morphologically abnormal sperms will also be more when you obtain it after a long period of abstinence. Clear? Yes. Now, what are the collection methods of semen analysis? So, collection methods may include masturbation in a clean container and you can even advise them to undergo an intercourse by using stylistic condoms that is not containing spermicidal agents. Okay. And the next one is where you can do. It can be done in a private room, in a laboratory or at home itself, but when transporting the semen sample from home to the lab, it should be transported at a room temperature and the sample should be brought to the lab within 1 hour after ejaculation. Okay, so these are the criteria if it is done in the home. Okay. Now, let's see about the WHO parameters of semen analysis. So, what are the WHO parameters of semen analysis? Okay, so this is very important. I am again putting this into macroscopic examination and microscopic examination. So, you know how it will be in both macroscopic picture and microscopic picture. Okay. So, macroscopic examination, the color, okay, say the color or appearance, normally it is white to grey opalescent, okay, and liquefaction, I told you it is 20 minutes for liquefaction, but in medicine you can't always take one specific number, okay, we will be giving a average duration. So, here we can take plus or minus minutes, so 15 to 30 minutes we can give while examining, okay. And the next one is viscosity. Normal viscosity will be smooth and watery, okay. So, this is how the macroscopic examination of the semen will be. Now, coming to the microscopic examination, okay, microscopic examination, and here we have to know about the semen parameters, okay, which is very important, okay. First point is sperm count. Sperm count, normally it should be 15 million per milliliter or more, okay. Minimum it should be 15 million per milliliter. So, equal to or more than 15 million per milliliter of sperm count. Then you have to see the total motility. Total motility of the sperms should be 40% or more. Then you have to check for the progressive motility. It should be 32% or more. And then morphology, okay, how is the size and shape of the sperm, that should be 4% of the normal forms. And vitality, vitality means the proportion of sperms that are alive, okay, so that is viability or vitality, okay. So, that is alive means it is 58% or more, okay, more than or equal to 58%. And semen volume, okay, the volume of semen obtained should be 1.5 milliliter or more. And then white blood cells. Okay, so white blood cells should be less than 1 million per milliliter. Clear? So these are the 7 parameters you have to know. If you ask me what is this total motility means, the total proportion of sperm that can swim, okay, that is actively motile. Okay, progressive motility means the ability of the sperm to swim in one direction, one particular direction. So it should be moving in this direction only. Okay, it shouldn't go this or this. So this is not acceptable. Okay, one single direction it has to swim, that is progressive motility. Okay, so that's it. I hope this WHO parameters of semen analysis is also clear for you. Okay, now so when you obtain semen, and if you are going to analysis for microscopic examination, you have to centrifuge it first. Okay, so semen specimen has to be centrifuged at a high speed, say 3000 degrees for 15 minutes, and the pellet that has settled down has to be taken for examination. Okay, you will have 2 layers after centrifugation, all the sperm will be settling down. Okay, so that is the pellet. So that should be obtained for examination by using a high magnification. Actually, it's around 400x. Okay, and if you talk about the average sperm count, it is going to be 50 to 100 milli international units per milliliter. And then if you ask me, ma'am, we have discussed so many parameters, which is the most important parameter that will be taken into consideration? Means the most important parameter is going to be morphology first, followed by motility, and then the sperm concentration. Clear? So this is the most important criteria we have to look. And I have to tell you about certain terms that are used in male infertility, which will be confusing as well, and which is also important for you to know, okay, to address a patient because this condition is present in this male, and so the infertility is present. Okay, so like that, if you have to address means you have to know some terminologies. Like, let's see the term as well as its definition. Clear? Yes, let's start this. First thing is aspermia. Okay, so aspermia means there is no ejaculate itself. Clear? And second one is azoospermia. Azoospermia means there is semen, but there is no sperm in the semen. Okay, so no sperm in semen. Next one is oligospermia. Sperm density is less than 20 million per milliliter. There is something called as severe oligospermia. Okay, severe oligospermia means the sperm density will be less than 5 million per milliliter. You have another condition, that is azoospermia. Azoospermia. Okay, azoospermia means there is reduced motility. Okay, there is reduced motility of sperms, or there is immotile sperms. Okay, astheno means you will be speaking about the motility. Clear? And then we have teratozoospermia. There is increased number of abnormal sperms, morphologically abnormal sperms. Increased number of morphologically abnormal sperms. Next one is leukocytozoospermia. There is increased WBC count, that is more than 1 million WBC per milliliter. And then you have oligospermia. So everything will be combined now. Oligo means there is low sperm concentration plus there are dead sperms, teratO, dead sperms, okay, and astheno, there is reduced motility of the sperms as well, okay. So all these conditions can coexist, then you can call it as oligoasthenoteratozoospermia. So these are the different terms we will be using to address the semen condition of a male, okay. Yes. Now, what are the other investigations you have to offer? So the other investigations you can offer to a male include your anti-sperm antibody test, okay. Here we involve two tests, namely immuno-B test and MAR test, okay. What does MAR test means? It is mixed agglutination reaction, okay. So what are the indications? What are the indications of doing this test? If there is any abnormal semen profile is seen, and then if there is a failed vasectomy reversal and there is marked agglutination, okay, that is 10% of the agglutination is present, okay. So this is important, okay. And then you have to check for CBC, if there is infection is present or not. You have to give your TFT, you have to do your urine analysis. If needed, you can even go for sperm culture or sperm function tests, okay. And hormone assays can also be done, which will include testosterone, prolactin, FSH, vasography can be done, scrotal USG, transrectal USG, MRI, DNA integrity testing, okay, to check the DNA damage is present or not. Then measurement of RDS species as well, okay. So this is important because sometimes oxidative stress mediated damage can also be present, which can damage the sperm membrane, and this may account for defective sperm function, that is especially defective sperm function and integrity of the DNA will be affected. Clear? Now, let us see how will be the hormonal profile in a male. So, hormonal profile assessment in a male with infertility, okay. So, number one is, if there is say if the male is having azoospermia or oligospermia and there is a small testis and the FSH is high, okay. So, what do you suspect in this case? Because the gonadotropins are trying to act more and stimulate the testis, which is not responding now here. It is the testis which is not responding. So, that means the patient is having a primary testicular failure. Can you understand me? Yes. And the second set of investigations we get it as azoospermia, where you have a normal testicular volume and the FSH is also normal here. So, testis is normal. So, the FSH is not going to stimulate above its normal value. So, FSH is also normal, but you don't get any sperms. That means there is, yes, very good, it is going to be obstruction. Okay, so there is bilateral genital tract obstruction, or even we can add one more kind of syndrome that is going to affect the Sertoli cells alone. So, that is Sertoli cell only syndrome. So, these are the two conditions that can present with these parameters. Okay. And the next one is, suppose the FSH is very low or undetectable. FSH is very low or undetectable. Remember, you have to check the other hormones now as well. Okay, LH is also low, testosterone is also low. What you will have? You will have hypogonadism. Okay, so everything is low, right? That means the patient is having hypogonadism. Okay, and the next one is, suppose if the LH is high as well as the testosterone is also high, but still the male is having infertility. What do you suspect in this case? Yes, the hormones are produced normal. Whenever a hormone is produced, it is going to act on a cell, and in the cell specifically on the receptor. So, there is a receptor defect. So, there can be androgen receptor defect. Clear? Okay. Now, I will tell you about one more study that is done in infertile males, that is nocturnal phenyltumescence study, or we can also call it as NPT study. Okay, NPT study. So, in this study, you have to understand that a man who gets strong erection when sleep, okay, and there is no erection when he is with the partner, then there is some kind of psychological impotence is there. Okay. So, this morning erection and stiffness, it is going to be present only in the psychological cause, but not in the organic cause. So, there is an organic cause, even this morning stiffness is not going to be present, early morning stiffness. Clear? Yes. Now, how we are going to manage a case of male infertility? So, management. What are the general measures we have to do? So, general measures, you have to give emotional support. Okay, so that is the first point. Give emotional support to reduce stress in both the partners. Then improvement in general health means you have to ask them to avoid smoking, alcohol or drug abuse. Then you have to reduce heat around the scrotum as well. Okay. Now, the next one is medical management. You have to first treat the genital tract infections and endocrinopathies. Okay, so this should be treated, that is the first point. And if you find anti-sperm antibodies, you have to give dexamethasone, okay, steroid at a dose of 0.5 milligram daily for 10 days, okay, in each cycle for 3 to 6 cycles, that is for 3 to 6 months, okay. And the next management you can do is you can supplement them with antioxidants, because we have seen oxidative stress is also one cause, right. So antioxidants that should be supplemented include your vitamin A, vitamin C, N-acetylcarnitine, then carnitine acid, okay. You can even give pentoxyphylline, okay, that is given to improve the sperm quality as well as to prevent the DNA damage. And next one, you have to ask if there is a history of premature ejaculation. If that is present, we have to give them selective serotonin reuptake inhibitors, that is SSRIs. For example, we can give dapagliflozin at a dose of 30 to 60 milligram 1 hour before the coitus. Okay, this should be given 1 hour before coitus. Clear? Right. And the next one is, let's see the biggest scenarios. Hypogonadotropic hypogonadism. Hypogonadotropic hypogonadism. Suppose if there is hypothalamic failure, okay, there is hypothalamic failure, what you will supplement? Gonadotropin releasing hormone. Then both FSH and LH may also need to be supplemented to maintain spermatogenesis, okay. Suppose if there is pituitary adequacy, you can even give them injection HCG at a dose of 5000 international units IM route twice weekly, okay. It is not twice daily, it is twice weekly. That should be given for 12 weeks or 3 months, okay. And sometimes after that you can even give them injection FSH at a dose of 37.5 international units, that will be added thrice a week, okay. And HMG, that is human menopausal gonadotropin, can also be given at a dose of 150 international unit thrice a week for 6 months, okay. So these are the hormonal supplements you will be giving. You can give injection HCG as such, then you can give injection FSH and injection HMG, okay. Next one is hypogonadism. Suppose if there is hypogonadism, how will be treated? We have seen hypogonadotropic hypogonadism. So hypogonadotropic, that is at the CNS levels we are supplementing the necessary hormones, and hypogonadism level will be giving clomiphene 25 milligram daily for 25 days, and following this you have to give 5 days of rest, and this should be given for 3 to 6 cycles, okay. Next one is surgical intervention. So these are the medical interventions and medical management so far we have discussed. We are going to discuss about the surgical interventions also now, okay. Surgical interventions is mainly needed for grade 2 or grade 3 varicocele. Then if there is a block in vas deferens or a congenital vas aplasia. Okay. So, in that case, we will be going for microsurgical vas anastomosis, or we can even give a IVF option, okay, that is in vitro fertilization. Okay. Now, suppose there is azoospermia. What will we do? Azoospermia is mainly due to pretesticular cause, that is pretesticular azoospermia, where there is gonadotropin deficiency. So, because of that, there is no spermatogenesis. Okay. Another type of azoospermia is testicular azoospermia, which is simply the gonadal failure due to genetic, acquired or developmental causes. Okay. So, how we are going to manage this condition? Management will involve in utero insemination with donor semen. That is, so you have to get consent from the couple prior to doing this procedure, and then you can even go for sperm retrieval techniques. Okay. Sperm retrieval techniques that can be tried include your MESA, that is microsurgical epididymal sperm aspiration. Then you have PESA, which is percutaneous epididymal sperm aspiration. Then you have TESI. TESI means it is testicular sperm extraction, and you have percutaneous testicular sperm fine needle aspiration, also using a fine needle will be doing. Okay. So, this is all about male infertility. We have seen how much important male infertility in contributing to the infertility to the couples, what are the different causes, what is the physiology, and how we are going to manage it both medically and surgically as well. Okay. So, with this we will be completing this topic on infertility. Until we meet in the next topic, take care, happy learning, and bye-bye.